you will get your 3 clinic placements. So my name is Hessam. I'm an ophthalmologist. I run the teaching for UWA. There's also a junior doctor called Han, who you won't have met yet. He's the clinical tutor. You'll see him at the clinical skills workshop. So between us, we more or less are responsible for your teaching. Oh, there's Han. Is that you? It is too, hiding up the back. Obviously you'll have ophthalmologists in the clinic placements too. Today is the sort of intro lecture to what is the eye, how do you assess the eye, how to refer patients, what to refer, and also what your curriculum is and what your assessments are going to be. So, and then there'll be a second lecture later this term. And then towards the end of the year, if you want a revision lecture before your final exam, we can also do one. Then some groups have requested that and some haven't in previous years. So today, as I say, we'll go over the unit itself, then we'll talk about some anatomy and optics, history and examination, some basic procedural skills that you'll need to know, guidelines on when to refer, and then hopefully a bit of time for question and answer at the end. So as far as what teaching you'll get, this is lecture number 1. There'll be a second lecture, as I say, that's on Friday the 6th of August at 1 p.m. back in here. And as I say, you can have an additional lecture if you want that. The clinical skills workshop is at the end of this month on Friday. That's at 2:30 p.m. at Charlie's. I won't be there myself for that one, but there'll be other ophthalmologists there as well as other registrars and so on. You'll have your 3 eye clinic sessions, and as a reference, we've got a bunch of these lectures recorded on, they're on a channel on YouTube, and also we've got a dedicated website as well. It's eyeballsmadeeasy.com.au. So there's clinical skills videos on there, and there's some lecture videos on there as well. But I think there's more on YouTube at the moment, so try and find that channel on YouTube. Pretty much our whole curriculum is on that channel. So every core condition that you need to know is addressed in one of the lectures that are on there at the moment. So I encourage you to watch all of those if you can. It's about probably 4 hours worth of viewing, but that pretty much covers the whole curriculum. Okay, so assessment-wise, your end-of-term exam is Friday the 10th of September. There are 25 picture-based questions. So that means a picture goes up on the screen for a minute, and then there'll be some short answer questions about that picture. So let's say a picture of a corneal abrasion. What is this? How do you manage it? That sort of thing. There are then 20 multiple choice questions. You've got 20 minutes for all of those. Take as long as, well, you know, it's flexible with the time. So it's not 1 minute per question sort of thing. Your end of year exam, there's a written component and an OSCE component. The OSCE is on the 19th of November. That's on a Friday. Usually there's a morning session and an afternoon session. So there'll be 1 eye station. I'm usually one of the examiners at that. And then the written is the following week, where you've got an extended matching question. So you've got a bunch of questions and then a bunch of diagnoses, and you match them. And then there are some short answer questions as well. Everything in the OSCE, in the short answer, extended match, comes from the content that's taught to you. So we're not going to throw you any curveballs. If you are here at this lecture and the next one, and you watch the stuff that's online, then you'll have covered whatever we assess. If supplementary exams are needed, they're likely to happen early next year. And there's usually an ophthalmology station at that exam. Okay, any questions about any of that so far? Or everyone happy? Okay, this is the structure of the unit, okay? So this is lecture number 1, Fundamentals and Introduction to Ophthalmology. All the rest of the stuff is online, but I might address some of it in your second lecture as well. I haven't actually decided what I'll do the second lecture on, but I'll pick something. You're welcome to contact me with requests or suggestions if you want. We've got an email address. So if there's an area that you're really not sure about, having watched some of the stuff online, and you want clarification, there was a year group in the past that requested a lecture on optic neuropathies, for example. So I gave a whole lecture on that topic. So you're welcome to do that. Red eyes and red flags. Patients come in to see you with eye problems because they've got a painful red eye. That's one of the most common presentations. The other common presentation is visual disturbance, which is either acute or chronic, okay, or subacute, somewhere in between. So red eyes and visual change, that's why people come and see us. You've then got systemic disease, which creates ocular manifestations, so things like hypertension and diabetes. And then there's some stuff on the impact of visual impairment. What's it actually like to live with a visual impairment? What are the most common causes? A bit of epidemiology, that sort of thing. So that's more or less the content that we want you guys to know. These are the conditions. So this is a bit of a scary slide, maybe, if you haven't seen it before, but it's broken down into red eye and visual disturbance. There's about 50 conditions on there. Probably 10 to 15 are the absolute essential ones, and they're the ones that are most commonly talked about in our lectures. Today I won't really be talking about clinical conditions, but as I say, we can do that in the second lecture. So it's either a red eye or it's a visual disturbance or it's both. And that's one good way to approach ophthalmology. Another way is to think of things as common or serious and urgent or both. So for example, microbial keratitis, an infection of the cornea, is not uncommon. We'd see these every week in a public hospital, but it's definitely serious and urgent as well. So this is another way to think about, the curriculum. As a general rule, anything that's both serious and common, you absolutely have to know. So the intersection of that Venn diagram is a good way to prioritize your learning. Start with that and then go outwards from there. The amount of content that you need to know for each condition, one palm card or one PowerPoint slide, okay? That's about how much information you need to know. How do they present? What are the symptoms? What do you expect to find on examination? And what's your management and what's the follow-up? And much of the time, your management is going to include referral to ophthalmology. Okay, it's just common sense. So each condition shouldn't really take you more than, I would say, 5 minutes to get your head around, to really understand, 5 to 10, let's say. So hopefully that makes that slide a bit less daunting. All right, so that's the curriculum more or less. Let's now talk about some basic anatomy and physiology. The eye essentially is like a camera attached to a transducer. A transducer is something that takes one form of energy and turns it into something else. Okay, it's like a piece of equipment in engineering. So the eye takes light energy, photons, and turns that into electricity, basically. The retina does that. So the retina is a biological transducer. The camera part of the eye, which is a focusing mechanism, is the front part. So the front part consists of the cornea and the lens. There are other things in there, the pupils in there as well. So the focusing part of the eye is the front, and the transducer part of the eye is the back. It's pretty amazing, really. So you can take light, focus it into a tiny beam, and that gets turned into electricity, and that's how we see. That's one way to think about the eyeball. Here are the structures that you need to know. So I've talked about, so this is a sagittal section, obviously. I talked about the cornea, okay, clear window at the front of the eye. There's the lens. It's clear when you're your age. Later on, it becomes cloudy. That's what a cataract is, okay? And you've got the iris here, which is sort of in a sagittal section. The hole in the middle is the pupil. So this is the focusing part of the eye that I talked about. So we call this the anterior segment, the front part of the eye. So cornea, anterior chamber, iris, pupil, and lens, okay? Obviously, you've got lids and lashes out here too. The cornea becomes the sclera, okay? It's continuous fibrous tissue. Anteriorly, it's clear. The sclera is white, so a different structure, but it's a continuation of the cornea. So the sclera forms the hard fibrous shell of the eyeball, which gives it its structure. You've then got the posterior segment, which mainly consists of the vitreous, which is like a gel, a jelly type structure inside the eye. And at the very back of the eye, you've got the macula. The central part of the macula is called the fovea. So you've got retina, the center of the fovea is the macula, the center of the macula is the fovea, okay? And so that's responsible for your high definition color vision is your central macula. So that's a very important structure. The macula then sends fibers to the optic disc. The optic disc is the cable to the brain, all right? So front to back, they're the bits that you need to know. What have I missed out? I've missed out choroid. The choroid is a continuation of the iris. So the iris at the front, which gives you your eye color. So when you talk about someone's eye color, you're talking about the color of their iris, right? The iris is a pigmented vascular structure, and it continues posteriorly as a pigmented vascular structure called the choroid. The choroid sits beneath the retina. So the retina is a light-sensitive nerve layer, and it's supported and nourished by the choroid, which sits underneath it. And it's the retinal cells which basically transmit towards the optic nerve and become the optic nerve, which then sends a signal posteriorly. So spend a little bit of time on that diagram and get familiar with those structures so you can name them, say, in a multi-choice question. So when you look at someone's eye, this is what you see. Basic stuff, upper lid, lower lid, okay? Medial canthus, the nasal side, lateral canthus, the temporal side. What's conjunctiva and what's sclera? Well, if it's white, that's sclera. The conjunctiva is clear epithelial cells sitting on top of the sclera. So unless you look really closely, the conj, in a way, is invisible. If you're looking on a slit lamp, you can see it, obviously. And if you put topical anesthetic in someone's eyes, okay, anesthetic drops, take a sterile cotton tip, you should actually be able to move their conj over their sclera because it's fairly mobile. So when you do your clinical skills workshop, you should do that on each other. Put anesthetic drops in, take a cotton bud, and just gently move, don't poke each other, gently move the conj around on top of the sclera. Conjunctiva has blood vessels in it, so you'll see those blood vessels moving over the white, okay? So over here, what's the most anterior structure? I've got iris, pupil, and cornea. So what's the frontmost part of all that? Yeah. So the cornea in this photo is really only visible as this light reflection. This is the camera that took this photo. Okay, it's the flash from the camera that took this photo. So the cornea is clear. It's the only tissue in the body that's transparent. How do you have cells with organelles that are completely transparent, millions of cells? That's a topic for another lecture, but I think that's pretty amazing. The iris we've talked about, that's the colored part of the eye, and then a hole in the iris, central gap, is the pupil, which obviously can constrict or dilate. What's behind the pupil? What's the very next structure behind the pupil? You remember that sagittal section that we looked at? Any guesses? Lens, yep. Is that the same person? Can't see where that's going. Okay, someone knows their eyes. Well done. So the lens is right behind the pupil, and that's part of the focusing mechanism, okay? So here's another sagittal section, just to give you another view, okay? There's the cornea, here's the iris, all right? And the clear bit in the middle is the anterior chamber. It's filled with what we call aqueous humor, or basically salt water, essentially, biological salt water. Aqueous humor is created by the ciliary body, which is also the posterior extension of the iris, but creates aqueous humor and pumps it out into this little area, which is called the posterior chamber. And the aqueous humor then enters the anterior chamber, fills the anterior chamber with clear fluid, and drains out through something called the trabecular meshwork. So that's a flow of fluid within the eye, okay? It's like the irrigation system of the front part of the eye. There's a lens sitting behind the iris. This gap here is the pupil, okay? Here's another view of that. So there's our lens. There's the ciliary body. Here comes the aqueous humor and travels out around the iris, drains into the trabecular meshwork. The trabecular meshwork is at the junction of the iris and the clear cornea, okay? Now, what do you think would happen if the iris got stuck to the lens? Just think about it logically. You've got fluid getting pumped out here, this gets stuck to this. What's going to happen to this fluid? Yep, it's going to accumulate underneath the iris. So now you've got basically a closed space with fluid which is continuing to accumulate What's that going to do? It is going to increase intraocular pressure. It's like if you're filling up a balloon, basically. And so that space is going to get tighter and tighter and tighter. The other thing it's going to do, it's going to push the iris forward. The iris pushing forward is then going to shut off the trabecular meshwork, which is going to push the pressure up even more. Okay? So that's what, if you've heard of acute angle closure glaucoma or closed angle glaucoma, that's what that is. So you get what's called pupil block. So the pupil gets blocked. It gets pushed onto the lens for various reasons. That's one cause of acute angle closure glaucoma. Pressure builds up back here. The iris bulges forward. The angle closes off. Pressure in the eye goes through the roof. It's a very painful condition. And it's not uncommon, and it's definitely serious. So that's a must-know condition. It presents as severe pain, blurred vision, periorbital ache. You know, the very first angle closure patient I saw when I was an ophthalmic registrar in the UK, actually, was vomiting. She was an old lady vomiting in an emergency department from the pain. So that's how these people present. It's a serious presentation. So that's front part of the eye, aqueous flow. All right, so here's a different part of the eye now. So the eyelids and the lacrimal gland. This is how we produce the watery component of your tears. The tear film is made up of 3 different layers. One of them is watery. That's made by this gland here. And then the tears eventually drain into your nose. That's why when people cry, they end up having a snotty nose as well, okay? That's where it ends up draining into. It drains through superior and inferior canaliculus. Their openings are 2 tiny holes in your medial canthus on the top and bottom lid. So again, in your clinical skills workshop, look for those upper and lower holes. They're called singular word is punctum. The plural is punctae. So inferior and superior punctae. So look for those on the slit lamp. You can actually see them, tiny hole in the eyelid. So normal tear flow is along the lid margin, into a punctum, into a canaliculus, into what's called a lacrimal sac, and then down the nasolacrimal duct. Okay, this is important because you get infection in here, in the lacrimal sac. That's called dacrocystitis. Dacrocystitis is an emergency because that it can extend posteriorly, and become orbital cellulitis, an infection within the eye socket. And orbital cellulitis is a potential threat to life. So you definitely need to know those 2 conditions, dacrocystitis and orbital cellulitis. Here's another view of those same structures. So inferior canaliculus, superior canaliculus, common canaliculus, lacrimal sac, nasolacrimal duct. And here it is again here. And there's your lacrimal gland, which produces your tears. So here's a CT scan of periorbital cellulitis, okay? So here's a little kid. You could say he's got a red eye. The eye itself is probably not red. The skin around it definitely is. So periorbital erythema and edema is what we'd call that. And the key thing here, the key thing you need to convince yourself is that this is not orbital cellulitis. It's just cellulitis of the skin, not of the eye socket. Eye socket, threat to life. Skin, oral antibiotics, usually fine, okay? So there's an approach to excluding orbital cellulitis. If you look on the scan, you'll see the tissue in the orbit looks pretty symmetric. You agree with me? And one test of that is if you've got orbital cellulitis, often the optic nerve is on stretch. So it loses this normal sort of natural kink. And also the intraorbital fat looks different between the normal and affected eye. What you can see here though is all the subcutaneous tissue was swollen. So it's clearly got an infection of the skin. Also with orbital cellulitis, you'll often have a sinus infection. That's often the source. So then you're looking at the ethmoid and sphenoid sinuses and you'll see they're filled with mucus. So this sort of imaging is examinable. You know, we could put up that image there of the CT scan and say, what's the normal eye? What's the abnormal eye? Is this orbital or is it only, you know, cutaneous? that sort of question. And what's your management? Oral antibiotics, regular review, ophthalmology consult. That's a sort of pretty standard question. So, yeah, but we won't throw anything at you that you haven't seen before, but as I say, if it's in the lectures, then it's examinable. Okay, what about how does the eye move? Who knows, who can remember which cranial nerves supply eye movement? Here's a test. Just name one. 6. Yeah, so 6, 3, 4. That's it, it's those 3. 3, 4, and 6. 5 is sensation, 7 is face, not eye, okay? So you really need to remember 2 muscles, okay? One is lateral rectus, which is supplied by 6, and one is superior oblique, which is supplied by 4. Everything else is supplied by 3, okay? So if you remember 6 does abduction, abduction, okay, lateral rectus. So if someone's got double vision on lateral gaze, let's say I've got double vision on right lateral gaze, you should immediately know that that's a 6th nerve palsy, right? My right eye isn't turning out, let's say. Left eye moves normally. So that's how 6th nerve palsies present. Okay, they present with horizontal diplopia on lateral gaze of the affected eye, And if you're examining me, my left eye would be doing this, my right eye would be looking straight ahead. So therefore I've got 2 images, right? So that's what diplopia is. It's 2 images that are not superimposed. 4th nerve palsy causes vertical diplopia. Okay, vertical diplopia, and often on down gaze. So a patient will say, I was walking down the stairs, there were 2 lots of stairs, or I was looking at the road markings when I was driving, and there were 2, or I'm trying to read, and I'm seeing 2 lines. So that's how 4th nerve palsy presents. And 4th nerve is responsible for downward movement in adduction. So when you're in adduction, adduction, 4th nerve turns the eye down. So when you're looking in and down, hence reading, stairs, whatever, that's when you get vertical diplopia from a 4th nerve palsy. So if you can remember those 2, everything else is a 3rd nerve. 3rd nerve palsy is down and out. You guys might remember that from medical terms or neurology terms. So the eye is turned down and out because the 6th nerve is still working, so it's pulling it out. And the 3rd nerve is responsible for turning the eye up. So if that's switched off, then it's going to go down. So down and out with ptosis, top lid coming down, because 3rd nerve is also responsible for keeping your top lid up. So lid down, eye down and out, that's a 3rd nerve palsy. You can have pupil involvement as well. I'm starting to go into pathology, which I shouldn't, but just know your 6 muscles, know your 3 nerves, okay? There's just another image. So medial rectus takes you in, lateral rectus takes you out, superior up, inferior down. That should all be pretty intuitive. You should be able to name these muscles and the nerves that supply them, okay? All right, you'll often see this picture in an exam. So get comfortable with this picture. What is it? What is this picture? Use normal language, it's okay. It's the eye. Which part of the eye? Yeah, it's the retina. It's part of the retina. It's the optic nerve and the retinal blood vessels. So we call this the ocular fundus, okay? Back of the eye, the fundus. Which eye is it? How do you tell right eye or left eye? It's okay if you don't know. Yes? How do you know? Closer to the? Yeah, good, good, good. So nerve is nasal. That's how I remember that one. Nerve is nasal. Therefore, and so this is, so there's the nerve. Here's the nose. Patient's looking at you. So when you're looking at a fundus photo, they're always looking at you, obviously. So the schnoz is going to be here. So it's the right eye, okay? What's this area? Yeah, the very center is the fovea. And so what's this area that I'm circling around? Macula, yep. So the macula is the center of the retina, the fovea is the center of the macula, okay? There's your optic nerve. So the macula is temporal to the nerve. The nerve is temporal to the nose. Okay? So nose, nerve, macula. Veins and arteries. Okay, so these are retinal veins and arteries. How do you tell the difference? The veins tend to be darker and thicker. All right? The arteries thinner, and they'll often have a sort of whitish appearance to them. So this is what a normal back of the eye can look like. And a simple way of thinking about it is everything at the back of a normal eye is either yellow or red or orange. All right? Red, yellow, and orange. And there should be nothing in between these blood vessels and the orange tissue. So it should basically be blood vessels superimposed on an orange background with a yellow nerve. If you're seeing black stuff back there, if you're seeing red stuff in between the blood vessels or yellow stuff, something's up. That's not normal. Often it is normal, but we're not going to show you, variants of normal. We're going to show you pathology. So I mean, I'll show you some abnormal pictures a bit later on. You'll see what I'm talking about. Honing in on the disc, I'll just point it out on this disc first. Just recognize that, okay, the disc is round, it's yellow, and in the center of the disc is a smaller round yellow circle, which is brighter than the rest of the disc. Does that show up on there? Yeah. Happy with that? So this is the disc margin, okay, the outside of the disc. This brighter bit in the middle, it's like a little hollowing out in the center of the disc. And that's called the optic cup. So you've got the optic disc and its margin, and then within the optic disc, you've got the optic cup. So there's the cup in the middle. There's the contour of the disc. This bit we call the neuroretinal rim. It's composed of neural tissue, basically. So going back to this picture, there's the disc, there's the cup. This stuff here is the neuroretinal rim. Why does this matter? Well, the main condition where this matters is glaucoma. So in glaucoma, the ratio of the cup to the disc, which in this case is about 0.4, I would say. The diameter of the cup to the full height of the disc, just under half, do you agree? Thereabouts, 0.3, 0.4, something like that. Similar in this one. In glaucoma, that cup-disc ratio goes up. Okay, so it goes up to 0.6 or higher. And I'll have a picture of that later on. So if you see two discs, right eye, left eye, and one has a much bigger cup than the other one, something's up. And if both of them have a very high cup-to-disc ratio, something's up. You need to think about glaucoma, all right? There's lots of other disc conditions which are covered in that lecture that I told you about on optic neuropathies, but that's probably the most important one that you need to be aware of, is the optic disc, the optic cup, and the cup-disc ratio, okay? All right, so that's enough anatomy. Let's now move on to some basic optics. So I mentioned earlier that the eye functions as a camera. So this is a little bit about what that means. So let's look at the top image first and think about a normal eye. Here come light rays from infinity, from a long way away. So they're horizontal and they're parallel. They hit the eye and they're bent, essentially, or refracted by a combination mainly of the cornea and the lens. So horizontal light rays, you might remember this from high school physics, but light rays get refracted by any material which has a refractive index capable of refracting light. My glasses, that's what they do. That's why I can see, because incoming light rays are bent in the correct direction so that we end up with a pinpoint of light at the back of the eye at the fovea, okay, at the center of the macula. If you don't have a pinpoint of focused light in your macula, you don't have a sharp image, right? That's why I need specs. Without specs, do we have myopia? Yes, we do. I'm this guy, okay? My eyeball is too long, right? So the image ends up being focused here, which is in the vitreous. It's not on my retina. So I end up with a blur, okay? This fuzzy image, can't see. Put glasses in front of me and the refractive power is corrected so that it falls on my retina, okay? So myopic or short-sighted people like me, the eyeball tends to be too long. And the opposite of that, hyperopic people, long-sighted people, meaning they can see well in the distance, but not up close, their eyeballs tend to be too short. So they need the opposite shaped lens, a convex lens, in order to increase the refractive power and shift this point of light from behind the eye onto the macula. Okay? So what you guys need to know is, in myopia, the image falls in front of the retina because the eyeball's too long, and you need a concave lens to correct that. Okay? Myopia means short-sightedness, means you can see short, but you can't see long. Okay? And those of you that are wearing glasses out there, you're probably myopic, like me. Hyperopia is less common in your age. So hyperopia or hypermetropia is the opposite of that. So that's someone who can see long but can't see short, all right? And they've got a short eye and they need a convex lens. They need the opposite. They need a convex lens to put the image in the right place. So I understand this is probably all new material to you, but there's not that much there really if you spend a few minutes on this slide to get your head around. So that's long-sightedness or short-sightedness. Now, I'm getting to the age where all my life I haven't been able to see very well in the distance, but I've always been able to see well up close because of the accommodation reflex. You guys might have come across that. That's where the refractive power of the eye actually changes and the pupil constricts so that you can change your focusing distance and read up close. Now you get to a certain age and you start to lose that. So I'm now getting to the age where I've never been able to see well in the long distance, and I'm now not being able to see well up close. It means you're getting old. It'll happen to you one day if you're lucky. And that's called presbyopia. So losing reading vision is called presbyopia. And so these glasses actually have a little reading bit in the bottom. You know, people talk about bifocal glasses. So the top bit allows me to see in the long distance, and the bottom bit allows me to read up close. And so this is what happens. This is what happens when you're younger, you guys. So you've got this object here, and the lens actually widens to increase its refractive power so that this focus point can be pulled in front, back onto your retina. Okay? So you're looking at something up close, that pushes the image backwards behind the eye. Accommodation reflex thickens up the lens and the image gets pulled forward. Okay, whoops. Well, as you get older, the lens can't do that anymore. Okay, so instead, you need a piece of glass in front of your eye that does that. So this is what reading glasses do, all right? So presbyopia happens in 40-plus-year-olds, that's the average age. So a patient comes to you, oh, doctor, I'm having trouble reading, I get headaches when I read, I think I'm going blind, I'm really worried. How old are you? 42. Do you have reading glasses? No. There's your answer. I literally see this every few weeks in clinic. It's like the easiest problem to solve. So that's your presbyopia presentation, okay? 40-plus-year-old used to be able to read, now can't. Obviously, there are other causes of that, but this is the most common cause, okay? So that's enough optics, all right? Myopia, hyperopia, and presbyopia. Those three things, know what they mean. Ooh, there's a bit more, astigmatism. I haven't put a slide in for astigmatism. So astigmatism means normal eyeball should be round, like a soccer ball. An eye that has astigmatism is not round. It's not perfectly round. One axis is more curved than the other. So more like a footy, like an AFL ball. Okay, that's extreme, but you get what I mean. So one of the axes might be round, but the other one might be more like a cone. Or the other axis might be very flat. So you get an irregularly curved surface. That's astigmatism. They just need a special type of spectacle lens to correct one of those axes of curvature. So that's the fourth type of refractive error. Refractive error means need for glasses. That's the fourth type of refractive error that you need to know. You need to know myopia, short-sightedness, hyperopia, long-sightedness, presbyopia, reading glasses, astigmatism, special lenses, you know, that correct for astigmatism. Okay, I'm gonna have a drink of water because I'm drying up. Any questions so far? Still with me? No one's dozing yet, so that's always a good sign. All right. So let's move on to the ophthalmic history. Okay, so structure of ophthalmic history is like the structure of a general medical history. Okay, presenting complaint, history of presenting complaint, past history, optical history, we stick in there. So that means, does the person wear glasses, contact lenses? Do they have bad short-sightedness or bad long-sightedness? Okay. Some of the medications are specific to ophthalmology. So has anyone heard of hydroxychloroquine or Plaquenil? You've heard of that? Yeah. It's used for many autoimmune conditions. Prednisolone you would have heard of, amiodarone I'm sure you've heard of, and ethambutol. So they can all have toxic ocular effects, which will be covered in another lecture. Let's go back to the top. Presenting complaint-wise, which eye is it? Is it one eye, both eyes? Is there pain or no pain? Is the vision affected or not? Okay. In the history, the most important thing, in the history of presenting complaint, the most important thing probably of anything is the rate. So whether it's acute, subacute, or chronic. Was there trauma at the time? You know, yeah, I was hammering away and now I've got a painful right eye. Well, that's going to be a foreign body, you know, until proven otherwise. Medical surgical history, diabetes is really important because of diabetic eye disease, okay, which is kind of its own thing. And have you had surgery recently or an injection in the eye recently? Because they're risk factors for infection, okay? So acute red eye after recent surgery or recent injection, that's an infection until proven otherwise. Family history, glaucoma, age-related macular degeneration, that's what ARMD stands for. That's an important cause of chronic progressive visual loss. And squint or strabismus, you know, when someone's got an eye that's deviated. All of those things can run in families. And then systems inquiries, recent infection, overseas travel, and inflammatory arthritis type diseases have ocular associations, okay? So that's the approach to ophthalmic history. Which eye? Is it painful? How's your vision? How long's it been there for? General medical history, do you wear glasses, contact lenses, and so on, okay? So let's focus in a little bit more on the presenting complaint and the history of the presenting complaint. So as far as the type of disturbance, we talked about pain, visual blurring or loss. Other types of visual disturbance are diplopia. I mean, the vision might be fine, but you've got two sharply focused images, which you didn't have before. Eyelid position, people can present with an altered eyelid position. So the lid's drooping down or they can't close their eye, okay? You know, Bell's palsy, for example. Pupils, anisocoria, so if you've got one pupil that's a different size to the other, which is new, then you need to think about a Horner syndrome or a third nerve palsy, okay? And altered color vision. So a person can have perfectly good vision on an eye chart, you know, at distance on a Snellen chart, but they'll say that the vision in one eye, the colors look more washed out than the other. So these are the types of things that people present with. Rate of onset I talked about, is it sudden and acute? Is it subacute, so it's more like days to weeks? Is it chronic, so it's more like months to years? And is it episodic or intermittent? This is an important one in ophthalmology. So the visual loss, is it central? Is it in the middle? And is it homonymous? So is it the whole right side of the world in both eyes? Or let's say, is it bitemporal? So it's a temporal side in both eyes. That'll give you an idea to where in the visual pathway the problem is, the lesion is. Associated symptoms are important. So does anyone know who tends to get flashes and floaters or what that's kind of like a signal for? Have you ever heard of that? So flashes and floaters, you need to be thinking of a retinal detachment, okay? The retina falling off the back of the eye. So that tends to present with flashes and floaters. Scintillations is common in migraine, okay? So people will get a visual aura, which can include flashing lights and a moving light, scintillations, and then discharge, which you tend to get conjunctivitis. So clear mucus discharge or a thick white discharge if it's bacterial. Associated activities, I talked about. Tradies often will get eye injuries. So the most common activities there are grinding, drilling, welding, hammering, and plastering, those things. So they walk into eye clinics every day, these guys, usually with a foreign body injury or a chemical injury. And then finally, what's the functional effect, or when do you notice it? Oh, I notice it when I'm driving. Do you also notice it when you're reading? No. So that's distance vision. The reading vision is not impaired. Walking downstairs, I talked about, okay? And computer screens, that's also near vision. Okay, so then let's talk about a few causes of painless acute loss of vision or subacute loss of vision. So this is minutes to days. It's usually unilateral. It's rare to get bilateral sudden visual loss. Bilateral sudden visual loss is a massive central event, something in your brain until proven otherwise, okay? And usually it's the back of the eye, the posterior segment. And because it's sudden, you know, most things in the body, if they're sudden, it's often vascular. It's often a vascular event. So here are some examples. This is what's called a central retinal vein occlusion. Central retinal vein occlusion. So it's a blockage of the central retinal vein. You can imagine if the vein's blocked, then the pressure in the veins, you know, of the blood that's returning, the pressure within the veins goes up, those veins become leaky. They should be watertight, they become leaky, and they leak blood into the entire retina. So you can see, you remember that picture of the normal fundus? I said there shouldn't be anything in between the retinal vessels. Well, you can barely see the retinal vessels in this picture because there's so much blood around. So if you see blood in all four quadrants, unilateral sudden visual loss, central retinal vein occlusion is a common cause of that, okay? This one here, on the other hand, the bottom part looks really pale, do you agree? Whereas the top part of the retina looks normal. This is a branch retinal artery occlusion. So this retinal artery has become blocked. So the inferior half of the retina is infarcting, basically, is ischemic. So the superior visual field, remember if it's inferior retina, then it's superior visual field and vice versa. So this person will come in saying, I can't see the top part of my vision in that eye, okay? And the retina in that area is blanched, it's white. Here's an optic disc where you can't see the contour. You can't see that normal round yellow disc that we were seeing before. You can see it here. It's partly obscured here. It's completely obscured here. So this is an optic neuropathy of some cause, a swollen optic disc of some cause. So they're the sort of some of the conditions that cause sudden unilateral visual loss, okay? Some associated symptoms, well, we talked about flashes and floaters. So here's a retinal detachment. This bit down here is normal retina. This bit up here that kind of looks like it's bulging forward and has all these creases and wrinkles in it, that's what a retinal detachment looks like. So let's say in an exam or in real life, this would be, doctor, I had flashes and floaters and now I can't see the bottom part of the world in my left eye. So flashes and floaters, and we've got a partial scotoma. That sounds like a retinal detachment, okay? Pain on eye movements, that's typical for optic neuritis. So inflammation of the optic nerve. Glare, you get in lots of things, but often in uveitis, so inflammation of the eye from various causes. Distortion is metamorphopsia. So distortion means a straight line looks wonky, okay? So the edge of a table or a doorway, if the presenting complaint is, oh, things just look wonky or wavy, my vision's gone wavy. Older person, that's age-related macular degeneration, okay? And these are all symptoms that are on top of pain or visual disturbance. So my vision's not right. Well, can you tell me a bit more? Things look wavy or wonky. Okay, that sounds like distortion to me. So it starts to guide you down towards the diagnosis. Anything with double vision pupils or lids is usually a cranial nerve problem, okay? My lids come down. Ooh, sounds like third nerve. I've got horizontal diplopia. could be third or sixth. Vertical diplopia sounds like a fourth. Okay, so this is how you think about these things. And scotoma, scintillating scotoma I talked about earlier. So here's an example of the left side of the world being blurred out. It's not just central or just peripheral, it's the whole left side of the vision. And what you need to know here is this a binocular image? So the person's got both eyes open, or is it a monocular image? They've only got one eye open. If they've got both eyes open, it means they've got a homonymous left-sided hemianopia. Everything on the left in both eyes is affected. And so when you learn about the visual pathway, that will tell you where in the visual pathway it is. And it's basically posterior to the optic chiasm. We'll go through some of this in the clinical skills workshop. If it's only one eye and the left side of my field, let's say it's my left eye and the left side of my field is affected, it means the right side of my retina is affected. So it could be a nasal retinal detachment that's knocked out the retina in the nasal side. So you need to know, is it monocular or binocular? And then from there, you can really work it out intuitively, as long as you have a basic understanding of the visual pathway. So you could get an image like this. This is the image out of the patient's right eye. Here's a bit of history. What's your, give you some differentials sort of thing. And that's a real life presentation. Okay, so we've talked about painless sudden loss of vision, painless chronic loss of vision. Now, talked about normal retina. You had that image earlier on. What's the abnormal thing in this image that wasn't there in that first image? Remember, there should be nothing in between red blood vessels except for orange tissue. Anything else is abnormal. So you don't need to know what they are, but just describe it in simple language. Is the nerve normal or abnormal, do you think? Be brave, come on. Yeah, it looks normal. This orange tissue out here, is it normal or abnormal? Pretty normal. So where is your eye drawn to as the abnormal bit? This could easily be an OSCE question. In fact, it probably has been in the past. So it's not, I'm not tricking you. There's yellow spots in the macula, they don't belong there. Okay. Any idea what they are? It's okay if you don't know. Yeah, they're called drusen, and they're deposits at the back of the eye in macular degeneration. So those sorts of yellow spots in an elderly patient, oh, that's macular degeneration, okay? That person might have distortion, I talked about that earlier. So macular degeneration is one cause of gradual, chronic, painless visual deterioration, okay? What's the abnormal thing here? Ignore that bit of fluorescein staining down here. What do you think of that? Is that normal? What color should it be? Should be black, yeah. So what do you think that is? You know what's behind the pupil because somebody said that earlier. Lens is behind the pupil, so what's a white thing inside the pupil? I'm sure you know this. Cataract, yeah. So this is the commonest cause of visual loss in the world, all right? So a white cataract like that these days is not that common. More common in Aboriginal people, which is what this is a picture of. They tend to develop cataracts earlier and they present for treatment later. And I operated on one of these on yesterday. Yeah, can't remember my days. So cataract is a clouding of the lens, usually related to age, and it's a gradual progressive cause of visual blurring. Now, we talked about cup-disc ratios earlier. Is this a high cup-disc ratio or a low cup-disc ratio, this one here? High, yeah. What would you estimate it to be? What's a cup-disc ratio there? Just eyeball it. 0.8? Do you agree? Thereabouts? And so what's the first condition you're thinking of? Yes, glaucoma. So here are the four big causes of chronic progressive painless visual loss, okay? Simple need for glasses, cataract, glaucoma, and dry age-related. So macular degeneration very simply can be divided into dry and wet. Wet means there's neovascularization. There's an abnormal blood vessel in amongst these drusen. And this is covered in another lecture, but wet macular degeneration actually causes acute visual change. Dry is the gradual slow one, okay? Because a new blood vessel bleeds and leaks and causes a disruption in the retina. Okay. How you going, guys? You're hanging in there. Okay. I feel for you. It's a lot of material, but we'll get there. Okay. Painful red eye. Super common. All right. Most of the causes of red eye that I talk about, you need to know. So binocular painful red eye, usually conjunctivitis. That's the most common thing. That's a standard GP presentation. Allergic conjunctivitis can do that too, but then there's a history of hay fever, asthma, eczema, atopy. Very important to know if it's traumatic or non-traumatic. If it's a tradie, again, let's say, or someone who's had an accident, then you're already thinking traumatic eye injury, okay? There's not going to be any red herrings. If it's a trauma case, then it'll be a traumatic eye injury. And chemicals are a part of trauma. So a chemical is something like cement, let's say, or bleach. That could easily be, they present every day, these people. Other things that are important to know is this person a contact lens wearer? Because contact lenses are a predisposing factor to bad corneal infections. So if someone comes in with a painful red eye, it's unilateral, there's no trauma, you need to ask, do you wear contact lenses? Oh, yeah, I do. Did you take your contact lens out last night? No, I left it in. So that's a risk factor for getting an infection. So often what happens is people go out drinking, they fall asleep with their lenses in, drunk, and then they wake up with a painful eye. And that's a corneal infection until proven otherwise. Recent surgery or an injection I talked about. Anytime you poke an eye, you can introduce an infection, like any part of the body, right? Recent surgery, think infection. Discharge or watering, conjunctivitis, usually not in inflammatory things. Uveitis, episcleritis, scleritis, these are covered in another lecture, but they don't usually, they're the cause of an acute red eye, but they're not usually associated with discharge, okay? So conjunctivitis, bilateral, discharge. These causes of red eye, uveitis and so on, inflammatory causes, unilateral, no discharge, all right? So just an important thing to ask about. Has it been watering? Is there a discharge? Yes, no. And then recent infections elsewhere. So upper respiratory tract is conjunctivitis. That's a flag for conjunctivitis. Often you get a viral urti and then a conjunctivitis. Dental or sinus, that's going to your orbit. That's your orbital cellulitis risk factor, okay? So someone comes in, painful eye socket, everything swollen and red. Oh, I had a tooth extracted last week or whatever. So you're immediately thinking orbital cellulitis. Very broadly speaking, etiology of painful red eye, trauma, infection, inflammation, and then angle-closure glaucoma I talked about right at the start, right? So they're the four broad categories to think about in terms of painful red eye. What do you guys think this is? Can I have some guesses? Or let's describe it first of all. So this is how I think about it. Is it monocular or binocular? Binocular? Do you think there's discharge? Yeah, agree. Anything else? If you look closely, this part of the conjunctiva is actually swollen. Can you see that if you compare it to the other eye? So we call this chemosis. Chemosis is the equivalent of edema of the conjunctiva. That's classic for conjunctivitis, all right? So that's not the only trigger. The trigger is it's bilateral and there's discharge, clear discharge. So by far the most common cause of that is viral conjunctivitis, okay? So that's a viral conjunctivitis picture. What's the abnormal thing here? What's your eye drawn to? Any guesses? Are the lids and lashes normal? Yes. Cornea look okay? Not sure. What's this thing here in the middle? Does anyone know? Does anyone know why it's green? Yeah, that's a corneal abrasion. So a corneal abrasion is a scratch of the cornea. Okay, so this eye has been scratched. It's green because it's been stained with fluorescein dye, which you'll come across in your clinical skills workshop. Fluorescein is a chemical that absorbs one wavelength of light. It's actually an orange colored chemical, absorbs one wavelength of light and transmits a different colored light. So fluorescence is that property. It's a property of the material to absorb one wavelength and transmit a different wavelength. So fluorescein absorbs white light and transmits green light. And that's most accentuated when you actually use blue light. So when you play with the slit lamp soon, you can put fluorescein onto each other's eyes, turn the slit lamp to the blue color, and the whole eye will fluoresce a bright green. Now, if there's a defect in the corneal epithelium, that'll fluoresce even more because the damaged epithelial cells take up fluorescein and fluoresce really brightly. So fluorescein staining is something you need to be able to do as a GP or an emergency doctor. And it's a way of assessing, testing for corneal abrasions, damage to the cornea, damage to the conjunctiva, okay? I had a guy today who had one of these, and he had it because he was rubbed too hard with the tissue on his eyeball. So he gave himself a corneal abrasion. His eye was numb at the time. We anesthetized his eye, so he didn't know he was giving himself a corneal abrasion. What are you worried about here? We've talked about it a few times now. What's the worrying, what's the diagnosis that you have to rule out? Orbital cellulitis, yeah. Can't even see the eye, right? So if the skin around the eyeball is so swollen that you can't even see the eye, then it's very possible that the whole eye socket is inflamed or infected, okay? How are you going, what imaging are you going to order here? CT, someone say? Yeah. CT, orbits and brain, okay? So yeah, they're your 4 categories. What's this demonstrating? So let's say this is a normal person's vision, and this is the abnormal one. Talked about it earlier. What's the word for that? I just heard someone whisper it. Distortion, yeah. So distortion. So, and what's the condition that you think of when you think distortion? Macular something. Old person, macular degeneration. Middle-aged person with diabetes, macular edema, diabetic macular edema, okay? So this is called a grid chart, or an Amsler grid chart is what we call this. And we give this to patients who have macular degeneration to self-monitor their vision at home. They stick it on their fridge and every day they check with one eye and go, is it straight or is it wavy? Okay. I handed 2 of these out this morning before I came here. So an Amsler grid chart is what that's called. Okay, so moving away from red eyes and visual disturbance to eyelids and eye sockets, orbits. Eyelid abnormalities. So what's the abnormal thing here? Is it top lid or bottom lid? Bottom, and how would you describe it? What's happening with that bottom lid? Just in simple terms. It's flopping outwards, right? Yeah. So it's an outturned lid. It looks really loose and floppy, right? So that's, we call that an ectropion. Ectropion means an outturning of the lid, and entropion means an inturning of the lid. So this man has a lower lid ectropion. The most common cause is age, okay? So the problem with an outturned lid is he might not be able to close his eyelids fully over his cornea. So he's at risk of his eye drying out. I'm not sure why I'm saying it's a man. It could be a woman. It just looks like a man. He's at risk of his eye, the front part of his eye drying out, therefore giving himself an infection. Okay. What do you think's going on here? Chalazion, yep. So chalazion is a collection of waxy secretion which your eyelids normally make. You know, I said there's 3 layers to the tear film. One of them's water. You remember the lacrimal gland. Another one is like a waxy or oily secretion. It's called meibomian secretion. And we've got meibomian glands on the margin of our eyelids. And sometimes they become blocked, and that meibomian secretion builds up. So you've got this waxy lump within the tissue of the eyelid. That's what a chalazion is. And it's pro-inflammatory to the tissue around it. It's not an infection, it's inflammatory, okay? Most chalazions get better on their own. This one's probably going to need an incision. So if it's persistent, then they need an incision. But that's a classic picture for a chalazion. And then what's going on here? It's crazy eyes picture. What's the abnormal thing there, do you think? He's not trying to stare at you. That's his normal face. Okay? Any thoughts? Han Lim? No, go on. Who was that? Exophthalmos? Who said that? Yes, yeah, exophthalmos or proptosis. Basically, his upper lids have been pushed up because his globes have been pushed forward. And his globes have been, often the globes are pushed forward because the content in the orbits, the amount of tissue in the orbits has gone up or thickened slightly. And the most common cause of that is thyroid eye disease. So thyroid eye disease, the extraocular muscles, which we talked about earlier, they thicken up and it pushes the eyes forwards. And if it's bad, they can't close their eyes fully. So again, they're at risk of exposure, a bit like this first guy, different cause, but a bit like this first guy, they're at risk of exposure. So eyelid abnormalities, infection we don't have a picture of, but inflammation, here's an example, laxity, there's an example. Could this guy have bilateral tumors? Yes, but that's super rare. I wouldn't, that's definitely not the first thing I'd think of. And then orbital abnormalities, inflammation. Thyroid eye disease, essentially it's inflammatory. Infection, you saw the orbital cellulitis picture. Tumor, usually unilateral. And trauma, you'll have a history of trauma, okay? Diplopia, I'm not going to dive into thirds, fourths, and sixths. I've kind of touched on them already. But usually, diplopia is binocular, meaning if you cover one eye, the diplopia goes away. All right, so it's a result of binocular function having gone wrong. You can get monocular diplopia, which is uncommon, but monocular diplopia is from light rays getting split for some reason when they enter the eye. So if the surface of the eye is very dry, irregular, then light rays can get split unevenly. So severe dry eye is one cause. A cataract can be, is cloudiness, but that cloudiness can be not consistent, let's say, within the lens. So different parts of the lens are more or less clouded than the other. Light gets split, you get two images. Astigmatism I talked about earlier, if the front shape of the eye is super irregular, then light rays can get refracted in an irregular way. So you get two images. So that's just some of the causes of monocular diplopia, less common than binocular diplopia. So actually prioritize binocular diplopia when you're learning about diplopia. And yeah, this stuff's all covered in another lecture in more detail. This is a good website. I would say better than ours, unfortunately, at this point. It's more comprehensive, but one day we'll catch up to that guy. He's an ophthalmologist in the States somewhere. He's really good. He's like an animator and an ophthalmologist. Okay, so look, that's history. Examination, I'm not going to talk about today because that's going to get covered in your clinical skills workshop. But these are the things that you need to know and be comfortable with. Many of them we've got videos for online. So definitely watch those videos more than once before you come to the workshop because you'll get more out of the workshop. You'll hit the ground running. So there's no video on gross inspection, but gross inspection is just to say any obvious abnormality. Is there a squint, one eye pointing the wrong way? Do the eyelids look abnormal? Is there a bulging of, is there exophthalmos, as we talked about earlier? Visual acuity, there is a video for. Fundoscopy, there is. The rest of it we'll talk about in the workshop, okay? Slit lamp exam, there's videos for, and so on. Basic procedural skills, really there's two. One is to be able to put in eye drops safely, and there's a video for that. Another one is removing corneal foreign bodies. There's no video for that yet, but that'll get covered in the workshop as well. And you'll actually remove a foreign body off a pretend eyeball in the workshop on a slit lamp, okay? And so final section, moving on to how to refer and who to refer to, when to refer, those sorts of questions. The one thing to take away is have a low threshold for getting advice. This is in the real world as well as in an exam setting. But anything eye-related that you're not sure of, things go wrong when people don't seek advice. So you guys will be interns in public teaching hospitals. There'll be an on-call registrar 24/7. So that's who you approach and you talk to if you're not sure. Where to refer to depends what the problem is. So if you're a GP and you've got the person who needs reading glasses, they can just go to an optometrist, okay? They don't have to go to an ophthalmologist. If you've got a trauma situation or serious illness, then that sounds like emergency. So you go to an ED and usually they'll call the on-call ophthalmology reg, who will then come to ED and see the patient if the eye's involved, okay? And then ophthalmology more or less for everything else. And ophthalmology can be in the hospital or can be in the community, okay? So if you're in GP land, you'll soon enough know who your local ophthalmologists are. And if you're near a public hospital, you send them to the local eye clinic, to the ophthalmology department. Urgent referrals, obviously acute visual loss, pretty much any pain, potentially, but definitely in contact lens wearers. The issue with contact lenses is that the infections tend to be really aggressive to the point where some bacteria can essentially chew through the cornea in a day, in 24 hours. That's not common, but it's possible, and it's definitely possible for a person to permanently go blind if the contact lens infection is caught late. So paying contact lens wearer, urgent referral. Chemical injury, again, potentially blinding. The clock's definitely ticking. These are like time-sensitive conditions. And obviously any acute neurological change, from my point of view, that's a brain tumor until proven otherwise, right? What do you include in referrals? Always include visual acuity. So whether you do it or the nurse in ED or in your GP practice does it, include that. If you're talking to someone on the phone, this goes for any history, right? This is not specific to ophthalmology, but a great clinical skill to try and practice is summarize everything in 2 sentences and then go on to provide more history as it's needed. That's just a good clinical skill for any doctor. So I've got a 24-year-old with right-sided ocular pain. The vision's 6/18, was previously 6/6. They're a contact lens wearer, so I'm worried about microbial keratitis. So if I'm on the other end of the phone, I'm like, awesome, thank you, send. I'll see them. And then if I want more history, I'll ask you, okay? Low threshold I talked about for seeking advice. Other management, if you think they're going to need surgery, so bad trauma case, retinal detachment possibly, flashes and floaters, partial scotoma, get them fasted, okay, whether you're in ED or elsewhere. If it's a trauma situation and their tetanus vaccine is not up to date, give them that. If it's a giant cell arteritis query, you might have heard of that condition. If you haven't, you will during this term. Then do some baseline bloods, so full blood count ESR, CRP. So giant cell arteritis is unilateral visual symptoms in an elderly patient with headache or temporal pain and jaw claudication, so pain when they chew food. So that's a systemic inflammatory disease with an ocular manifestation. Can quickly blind someone if they're not treated, okay? And contact lenses we're talking about. If you've got a contact lens wearer in your clinic and he's got a contact lens is still in, then, and they've got their case, you know, the contact lens case or whatever, or they can pick it up from home, get them to take all that into the ophthalmology department because we culture all that stuff. So we want to know what's the bacteria, and often it's on the case or on the contact lens itself. One thing to remember is simple oral analgesia. This often gets missed for some reason in the exam setting. In real life, I'm sure you'll probably do it. But if someone comes in with really bad pain, don't forget to say that you'll give them some analgesia, all right? 2 things to never do: never discharge someone with anesthetic drops. In real life, it's going to be very tempting to do this. Someone comes in with a corneal abrasion, and it's a really painful condition. You put in an anesthetic drop and they're instantly more comfortable. They will thank you and they'll say, "Can I take those drops with me?" So unfortunately, I had to fail a student in an exam who'd done really well up to that point in the OSCE. And he said, "Yeah, I just discharged them with the anesthetic drops." And I can't say anything as the OSCE examiner. But if someone takes topical anesthetic drops for a long time, meaning a day or 2 days, they get a toxic keratitis. It's toxic to the surface of the cornea if they keep using it. So you never do that. Unless you've discussed it with an ophthalmologist and they're just going to use it for the next 3 hours until they get to the eye clinic, right? That's okay. Also, never discharge someone with topical steroid drops unless it's been discussed with ophthalmology. The reason for that is you might have a red eye and they've got a viral infection that, let's say, you haven't detected. So usually this is a herpetic infection, herpes simplex or varicella, chickenpox virus, and steroids will make that infection worse, okay? So again, patients like topical steroids. It settles down inflammation, but the infection goes through the roof because it's an immunosuppressant. And I saw a patient like this last year who'd been given topical steroids by someone. They'd used it for 2 weeks. By the time they got to me, they were pretty much blind in that eye. So never discharge on topical anesthetic, never discharge on topical steroids unless you've got the green light from ophthalmology. Okay, so guys, that's pretty much the end of the lecture. Hopefully we've gone through all of those things. The abbreviations that were in, those Venn diagrams at the start are included here. These slides will be made available to you on LMS, so you'll be able to download them. And next time I see you guys will be in the clinical skills workshop. So good luck with your clinic placements if you have one before then. And any questions?